All right, let's get right into it. Today, we're tackling a really tough but critical topic in transplant medicine, post-transplant lymphoproliferative disorders, or PTLD. Look, if you're a trainee in this field, getting your head around PTLD isn't just a nice to know, it is an absolute must. So let's dive in. So here's how we're going to break this down. First, what is PTLD really? Then we'll talk about how we try to stop it before it even starts. After that, what to do when you think you have a case, how we actually treat it, and we'll wrap it all up with what to expect and the big takeaways you need to remember. Okay, so first things first, what are we actually dealing with here? The most important thing to get right away is that PTLD isn't just one thing. It's a whole spectrum of disease, a continuum that runs all the way from something almost benign to a full-blown aggressive cancer. At its heart, PTLD is kind of the ultimate paradox in medicine. We give these powerful immunosuppressant drugs to make sure a new organ is accepted, right? But those very same drugs can cause this uncontrolled explosion of lymphoid cells. Usually it's B cells, and they're often supercharged by the Epstein-Barr virus, EBV. It's a life-saving treatment with a really dangerous catch. And this is where it gets really interesting. Think of PTLD not as a single spot, but as a journey through these three stages. You start with early lesions. This is like the warning shot. It can look a lot like a bad case of mono, and it's polyclonal, meaning all sorts of different cells are going wild. Then you can move to polymorphic PTLD. Now it's starting to look more like a real malignancy, but it hasn't quite met the criteria for lymphoma yet. And finally, you have monomorphic PTLD. This is the end of the line. It's a full-blown monoclonal lymphoma. Knowing where your patient is on this journey is absolutely key to how you treat them. So obviously, with something this serious, the best treatment is to never let it happen in the first place, right? This is all about being proactive. We can't just wait around for PTLD to show up. We have to have smart strategies in place from day one to mitigate that risk. And our prevention strategy really stands on these three pillars. Number one, use as little of the bad stuff as possible. That means we are super careful about tapering immunosuppressants, especially things like tacrolimus, down to the absolute lowest dose that still works. Number two, we go after the main culprit, EBV. For our high-risk patients, say an EBV-negative person getting an organ from an EBV-positive donor, we use antiviral prophylaxis. And number three, we hunt for trouble. We are constantly monitoring these high-risk folks, checking their EBV viral load so we can jump on any reactivation super early. And this right here, this shows you just how powerful that second pillar is. A really well-done study gave us this number. Just look at it, 0.62. That's the odds ratio for getting PTLD for every single month a patient is on ganciclovir. But what does that actually mean? It means this. For every month we give a patient prophylactic ganciclovir, we cut their risk of developing PTLD by a whopping 38%. That's not a small number. That's a massive, clinically meaningful effect. It's a huge argument for being proactive in the right patients. Okay, so let's say despite our best efforts, prevention fails. You have a patient and you're highly suspicious of PTLD. What do you do now? This is where the pre-treatment assessment comes in. A thorough, systematic workup isn't just a good idea, it's absolutely non-negotiable. And here's your checklist. You're going to order your basic labs, but pay really close attention to LDH and get that quantitative EBV PCR. You need good imaging of the whole body. A PET CT is really the gold standard here. You absolutely have to know how that precious new organ is functioning, and then, depending on what you're seeing, you might need a bone marrow biopsy if their counts were low, or a full CNS workup with an MRI and a spinal tap if you see any neurologic signs at all. All right, now for the main event, treatment. And let me just say, this is not a one-size-fits-all kind of deal. The therapy has to be specifically tailored to which subtype of PTLD we're dealing with, where they are on that journey we talked about earlier. But before we even talk about specific drugs, we have to face the huge, central dilemma of treating PTLD. I'm telling you, every single decision you make is going to be a balancing act between two goals that are in total opposition to each other. Can you guess what they are? And here it is. This is the whole ballgame. Goal number one, get rid of the PTLD. To do that, you need to reduce the immunosuppression so the patient's own immune system can wake up and help fight. But goal number two, save the transplanted organ. To do that, you have to maintain immunosuppression to prevent rejection. See the problem? You can't do both at the same time. This constant push and pull This tension is at the heart of every single treatment decision you will make. So how does that play out in practice? Well, for those early lesions, we lean hard into goal number one. The very first move, and often the only move, is to just back off the immunosuppression. A lot of the time, just taking your foot off the gas is enough for the immune system to get back in control and clear things up on its own. But if you're dealing with polymorphic PTLD, that's usually not going to cut it, so we have to escalate. We still start by reducing immunosuppression, but we add a new weapon, rituximab. As long as the disease is CD20 positive, and most of it is, we can use this antibody to specifically target and wipe out those bad B cells. And then, for monomorphic PTLD, which is basically a lymphoma, we have to bring out the big guns. This is a full court press. We reduce immunosuppression as much as we dare, we hit them with rituximab, and, more often than not, we add full-on chemotherapy, like the classic R-CHOP regimen. It's our most aggressive therapy because it's the most aggressive form of the disease. Okay, so we've covered what it is, how to prevent it, and how to treat it. Let's wrap up by talking about what to expect, the prognosis, and then boil this all down to the absolute must-remember takeaway. When you're trying to figure out how your patient's going to do, these are the red flags you look for. Things like older age, poor performance status, the more aggressive histology types, disease that's gotten into the brain or bone marrow, and labs like a high LDH. The more of these a patient has, the tougher their fight is going to be. So if you remember nothing else, remember these 4 things. 1. PTLD is a spectrum, not one disease. 2. It's always a balancing act. Kill the cancer versus save the organ. 3. Your best tool is prevention. Be smart with immunosuppression, use antivirals, and monitor closely. And 4. Treatment is a ladder. You escalate your approach based on the specific type of PTLD you're facing. And I'll leave you with this question, because it's not theoretical. One day, you will be in that room with that patient, and their life and that precious new organ are hanging in the balance. When that moment comes, how are you going to navigate that gut-wrenching decision to risk the graft in order to save the patient? That's the challenge. Thanks for listening.